So let's end up this basic EKG course with a few other rhythms that we'll kind of see here on the EKG. Right now we're going to finish up with the cardiac arrest setting. So your patient is in a wide complex rhythm. It's hard to really tell from far away, but you can see here. We can even allow options to be turned on so that it can tell us that this might be ventricular in origin. So after a certain period of time, it's watching for us. We'll determine that this is a wide complex with no pulse. Person has no breathing. We initiated CPR. We go ahead and place these pads on victim's chest. We'll go ahead and press charge. And what's going to happen is already defaulted. The first energy setting, if you see here, is 200 joules. It charged up pretty quick, and then we just press that shock button here in order to deliver the shock. Subsequently, after we press and defibrillate the patient, we continue to do compressions, working in our 2-minute cycle. And then when we go ahead and press charge again, it would go automatically up to the next energy setting at 300. So you'd see it defaults already to 200. The next time it'll go up, it'll default to 300 and so forth. Up to 360 is the max. Now if we needed to, for some pediatric patients, we need to start the energy setting really low. So the lowest we got is 2, and as you can see, it goes up incrementally, but then it just jumps from there on. So the machine is defaulted. Everybody is going to default to 200, 300, and 360. These are subsequent energy settings that when we are in the cardiac arrest victim for ventricular tachycardia and ventricular fibrillation will shock at those levels. Again, the pads usually come on and they're placed on. We were not only just placing the pads on, but you'd want to also attach the EKG cables to the patient. So you get EKG cables all attached, and that's where we would end up seeing multiple leads and multiple rhythms generated across the screen. So here we would see exactly that rhythm, that wide complex, no pulse, CPR is in progress. We'll charge it up once the pads are in place, and it'll shock at 200. We'll do 2 minutes of CPR, initiate some ALS interventions, charge again at 300 and 2 minutes, continue with ALS interventions, again charge up at 360. We would continue to deliver electricity at the 360 level unless something were to change. As we mentioned, as the electrical activity continues, it gets less and less organized, and the patient may deteriorate down into what's called ventricular fibrillation. Again, when we're shocking the patient, we are trying to reset the electrical conduction system and pacemaker site. It's not trying to jumpstart them. Eventually, this activity will continue to go down, and we know this if we do nothing about doing good CPR and chest compressions, the basic maneuvers, if we're not ventilating them, we're not performing good, solid quality CPR, allowing the chest to recoil, we're not going to be perfusing the heart and the brain, and we'll end up in what's called asystole. We know that over 10 minutes of downtime, the likelihood of survival is less if nothing has been done prior to this. Now, should we have started or find that we have now have some kind of activity that's on the monitor now as a result of our resuscitative efforts, this may be organized. As I can see, there's a P wave, a QRS, and a T wave, and this goes across. It looks like it's very regular. It seems to march out. The rate up here indicates that it's 72. I would consider this a sinus rhythm at 72 beats per minute. However, our patient still has no pulse and no breathing. As a result of that, even though it's a sinus rhythm, we would still call this a pulseless electrical activity because there's no pulse with this. Different forms of a wide complex tachycardia again. This is a ventricular tachycardia. It can speed up. It can then deteriorate into ventricular fibrillation. And it can even be somewhat organized in that the pattern seems to flip up and down. You'll notice that this is upward now, and then now we have a downward deflection, then we have an upward deflection, and then we have a downward deflection, and an upward deflection, and we're using the lead 2, right? That's our best lead to look at. This is your top lead here. You see that the points seem to flip up and down. And this is just called twisting of the points, or torsades. Again, this is not organized enough to generate a pulse, so the person would be in cardiac arrest.